Please let me know when I can start and once it is live.
Yes, we're live. Yeah, we're live, no? Madam, we are live. Yes, I'll just share my screen. Monica ma'am, is my screen visible?
Yes.
Thank you, madam. So, on behalf of Public Awareness Committee Foxy with E-Zone, episode 22, we cordially invite you all to Core Connect live webinar. It is today scheduled to start from 5 p.m. And for today, our conveners screen is not changing. Monica madam, is my screen changing?
No.
Yes, it is changing. Not right now. I can only see the first screen.
Just share one screen.
Yeah.
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 Changing. So we have Dr. Monica Madam, who is in charge of all the PAC activities for Foxy, and also we have Dr. Satabdi De, who is also the convener of PAC Foxy. Dr. Monica is currently obstetrician and gynecologist, Mangalia Nursing Home and Center, and she's also the website coordinator for Foxy. And currently, she's also holding positions in ISOPAR, and also she's a treasurer of AMA 21.
Please let it be. Don't read the entire thing. We waste time.
Okay.
Thank you
Okay,
so
ma'am.
much. Yeah, thank you so much for giving me this opportunity, and I'm very happy and privileged to host the 22nd episode of the Public Awareness Committee, Foxy. These webinars are a brainchild of our chairperson, Dr. Priyankur Roy, and we do it every 15 days with a particular theme in all the zones. So this time, our theme was AUB, perimenopause and osteoporosis, and we are doing this with the East Zone societies. And I'm very honored to have Dr. Janmajay Mahapatra and Shamal sir as the guest of honor for today. Jaideep sir, as the chief guest, is busy with some other issues of Foxy, and held up in a meeting. So, if possible, he will join later. I invite all the esteemed delegates and the faculty members to join in for a inauguration ceremony. Can we have the slide for the inauguration time?
Yes, madam. I'll just wait.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः.
Thank you so much. I take privilege in introduction of our guest of honor today, Dr. Janmajay Mahapatra sir. Can we have his CV, please? Yeah. Professor Mahapatra sir is currently the Vice President-elect Foxy for the year 2024. He has been holding various posts in all the capacities in various organizations, including the Foxy, the AICOG, the Treasure AGOI, the YOGOG Committee of Association of Gynecological Oncologists of India. He has been the organizing secretary of AICOG 2002 at Bhubaneswar too. We welcome you, sir, and we invite you for your precious words of encouragement for this webinar.
Thank you, madam, for your kind introduction. Good evening, everybody. Respected our President Foxy, Dr. Jaideep, our Vice President-elect, Dr. Shamal Seth, guest of honor of this webinar, my close friend. Chairperson Public Awareness Committee Fakshi, Dr. Priyankur Rai, Vice Chairperson Dr. Kalyan, conveners Dr. Rekha and Dr. Indranil Datta, Coordinator Dr. Monica, Dr. Satabdi De, speakers Dr. Himali Sinha and Dr. Jayant Margupta, Chairperson Dr. Pranay Phukan, Charu Modi and Dr. Rekha Jha, Dr. Hafizur Rahman, and moderator of the panel Dr. Soumyananda and Dr. Madhusmita, expert Dr. Avarani Sinha, all the brilliant panelists and all the office bearers of East Zone societies, my dear fellow delegates and friends. First of all, I am congratulating Dr. Priyankur Rai, our Chairperson Public Awareness Committee, Fakshi, for organizing today's wonderful scientific program, a live webinar, coordinating with all East Zone societies of Fakshi. And I am privileged to be the guest of honor of today's webinar. The topics to be discussed by brilliant speakers on HRT and osteoporosis and menopause, and panel discussion on AOB in perimenopausal age group. Thank you, organizers, for choosing these important talks and panel. I think it will surely benefit our members in their day-to-day practice. I welcome all the audience to this very important webinar and expect that you keep logged into the last so that we learn a lot that will help us to change our practice and ultimately translate to good clinical practice. Thank you all. Long live Fakshi. Hello.
Thank you,
Hello.
sir. Thank you for the kind words.
Thank you so much, sir, for the kind words.
Yeah.
Sir, Priyankur is busy in an exam. He's an examiner, so he has not been able to join, but he's given his best regards and sent a thank you message for all of you.
Okay. Thank you.
I request Shatabdi to please introduce our next guest of honor, Dr. Shamal Seth.
Thank you, Monica. Thank you, Janmajaya, sir. A very warm welcome to all of you. Our second guest of honor for today's session is Dr. Shamal Seth, sir. Sir is a senior consultant practicing gynecologist and a very well-known medical legal advisor. He is a visiting specialist at various hospitals in Kolkata. He has been the managing committee member and office bearer for the Bengal Obs-Gynae Society for 13 years. Also has been the secretary as well as the chairperson of the MTP committee of Foxy. Sir has been the vice president of the Bengal Obs-Gynae Society as well. It's a privilege to have you here, sir. Can you kindly have your words of blessings for the webinar?
Thank you very much, Shatabdi, for kind introduction, and thank you very much, Dr. Monica, for inviting me as the guest of honor of this beautiful program. You know, the Public Awareness Committee of Foxy has been doing an excellent job under the dynamic chairpersonship of our own Dr. Priyankur Rai. And the way this program has been planned out, starting from the HRT, then the osteoporosis, and then a panel on AUB around the perimenopausal period. You know, this is the period we find many of patients suffering from those kinds of hemorrhagic disorders, and that we need to give due importance to all those patients. So perimenopausal AUB, we are going to have a brilliant panel on that. And whoever will be attending this program will be benefited from all the deliberations by the brilliant speaker, with the beautiful panelists and the learned moderators. There is Avarani Sinha was there. My friend, let me congratulate first of all our own Foxy president, Dr. Jaydeep Tank. Let us all wish from the core of my heart a very happy birthday to Dr. Jaydeep Tank. And we all pray that all his dreams, all his wishes come true. My friend Janmajaya is there. I can see him always smiling at the service of all Foxians anytime he is called for. Thank you very much, Dr. Janmajaya. We see you a brilliant career ahead.
I'm always doing
Foxy. And with the program to be a huge success and of too much of information to be percolated to all those who are going to attend. Thank you very much.
Thank you, Samal.
Thank you, Janmajaya. How are you? All good?
Take chal raha hai.
Okay.
Sir, thank you, Shamal sir, and thank you, Janmajaya sir, for those words of wisdom and for encouraging us and being there. We will move on to our academic sessions. We have two talks today by two very as well as a very interesting panel discussion coming up. Our first talk is by Dr. Himali Sinha, The chairpersons for the talk are Dr. Pranay Fukan sir and Dr. Charu Modi ma'am. Can I have the slides, please? Dr. Pranay Fukan sir is a senior professor and HOD at Tinshukia Medical College, Assam. He has been a teacher of undergraduate as well as postgraduate for over 34 years. He has held various positions in Dibrugarh Afghani Society, as he has also been the president of the ISOPAR chapter of Dibrugarh, honorable secretary of the Dibrugarh Menopause Society, and he has various academic accomplishments to his credit. We welcome you, sir. Our next chairperson is Dr. Charu Modi ma'am. Ma'am is the East Zone convener for AHC Foxy. Ma'am is a consultant obstetrician and gynecologist at Modi Nursing Home, Patna. Ma'am has also been a active member of the Breast Committee, the Adolescent Health Committee, as well as PAC YTP Committee. She has various awards and publications to her credit, and her special interest is in programs related to adolescent health, public awareness, cancer screening, and safe motherhood. Welcome you, ma'am. I would like one of you to kindly welcome Himali Sinha, ma'am.
Okay, thank you very much. I feel privileged to be associated with this beautiful webinar, and which are very essential for our clinical practice. Especially, I feel that hormone replacement therapy or estrogen therapy or various cancers are greatly associated with some medical legal or some other problems. So I feel that Dr. Himali Hedi Sinha, she's a professor and head of the Department of Obstetrics and Gynecology, All India Institute of Medical Science, Patna. And then she's a professional interest in maternal and fetal medicine, social obstetrics, obstetric epidemiology. She's a WHO fellow for high risk pregnancy. She's such a good academician associated with EMOG, BMOG, SB, and all the training publications in various international journals, and co-edited so many books and then chapter probably. She is also associated with as an advisor of UPSC National Board. Anyway, we are very grateful that she has committed that she's going to deliver a lecture on this pro. I request Dr. Himali Hedi Sinha just to start her talk.
Thank you, sir. May I share my screen now?
Yes, ma'am.
Yeah. Is my slide visible?
Yes, Himali, make it full screen, please.
Yeah, it's becoming. I've just made it full screen. It will be there.
Yeah.
Right. Thank you, chairpersons. And first of all, I'd like to thank the organizers for inviting me. My topic of discussion is hormone replacement therapy. So I'd just like to just confess that I will not be talking in detail about osteoporosis and hormone replacement therapy in that, because the next talk is dedicated to osteoporosis in the menopausal area. Right. So let us start with the definitions. So menopause, starting with menopause, is the permanent cessation of menstrual periods determined retrospectively after a woman has experienced 12 months of amenorrhea without any other obvious physiological or pathological cause. So it's a reflection of complete or near complete ovarian follicular depletion, resulting in hypoestrogenemia and high FSH levels. There are other conditions: premature ovarian insufficiency, where menopause occurs before the age of 40 years, and the menopause transition, which occurs after the reproductive years, but before menopause, and is characterized by irregular menstrual cycles, endocrine changes, and hot flashes. So what is hormone replacement therapy? It is any form of medical treatment in which hormones are administered to supplement the lack of naturally occurring hormones. The treatment replaces hormones the body can no longer produce due to age, damage, or premature failure of the reproductive organs. It is used primarily as medical treatment of menopausal symptoms. So I will be going through this, the various, this is just a flow of my talk. Right. So the endocrinology of menopause: there is depletion of ovarian follicles and resistance to estrogen, impaired folliculogenesis, decreased estradiol production, decreased negative feedback effect on the HPA axis, and leading to increased FSH level. Again, decreased inhibin release also contributes to this. So we find that there's a huge difference between the level of hormones in the menopause compared to the premenopausal area, where we find that there is decrease in circulating estrogen, decrease in the ratio of estrogen to androgen, decrease in sex hormone binding globulin secretion, increased peripheral aromatization of DHEA to estrone, and there is reversal of the estradiol to estrone ratio, but there is no significant change in the testosterone level. So we find there are various changes in the organs. All of them are basically going atrophy. So what are the health concerns during the menopause? There are vasomotor symptoms, urogenital symptoms, osteoporosis and fractures, cardiovascular effects, cerebrovascular effects, psychological changes, skin and hair changes, sexual dysfunction, dementia, and cognitive decline. So the vasomotor functions are, symptoms are hot flushes experienced by about 75% women. This can continue up to almost up to 10 years. Then what are the hot flushes? There's acute sensation of heat and skin changes, including sweating. And this may be caused by an increase in FSH level or decrease in estrogen level. And the treatment is estrogen. There are urinary symptoms. There's increased frequency, urgency, and dysuria, which is common and troublesome. The lining epithelium of the lower urinary tract is dependent on estrogen for its integrity. Estrogen deprivation at menopause induces changes in the uroepithelium, and these changes predispose to frequent UTI. There are mood disturbances. Fluctuating estrogen levels lead to reduction in central neurotransmitters, serotonin, which leads to mood changes like depression and anxiety. Estrogen replacement therapy ameliorates these symptoms. Some progesterones increase these symptoms. So the treatment of postmenopausal symptoms may be either non-hormonal or hormone replacement therapy. I will be confining myself to hormone replacement therapy. Oh dear. Just a minute. So hormone therapy encompasses both estrogen alone and estrogen progesterone therapies. Estrogen therapy, there is unopposed estrogen prescribed both systemically for women who do not have a uterus and also locally in very low doses for any women with vaginal symptoms. Estrogen progesterone therapy, and progesterone is added to the estrogen therapy to protect women with a uterus against endometrial cancer, which can be caused by estrogen alone. There are bioidentical hormone. There is also bioidentical hormone therapy consisting of hormones chemically identical or very similar to those made in the body. So what are the preparations available? Estrogen alone or combined estrogen and progesterone or selective estrogen receptor modulators, or there can be gonadomimetic, something like tibolone, which has weak estrogenic progesterone and androgen action. Which are the commonly used estrogens? Conjugated estrogen, micronized estradiol, 17-beta estradiol, and estradiol, which can be used intravaginally. So continuous estrogen is prescribed in women who do not have a uterus, who have undergone hysterectomy. There is no tablet break, and of course, there is no bleeding because there is no uterus present. Continuous sequential hormone replacement therapy is given, may be given in women who have a uterus. Here, after day 14, for about 10 days, progesterone is added sequentially without tablet break, which leads to regular bleeding at the end of the cycle. Or we can prescribe continuous combined HRT where estrogen and progesterone, they are given continuously without a tablet break. And of course, there is no bleeding at the end of the cycle. So considering the risks, hormone therapy should be used with lowest effective dose for a short period of time. Dose should be modified or may be stopped if symptoms are controlled. There are various routes of administration. There could be oral therapy or subdermal implants or percutaneous estrogen gel or a transdermal patch. Vaginal cream is effective for atrophic vaginitis. It reduces the urinary frequency, urgency, and recurrent symptoms and is suitable for women who do not wish to use systemic hormone replacement therapy. Any woman with a uterus on oral or transdermal estrogen must also be prescribed progesterone to prevent endometrial cancer. Micronized progesterone is better tolerated with fewer side effects and decreased risk of invasive breast cancer. In patients with a history of breast carcinoma or endometrial carcinoma, progesterone can be used that is medroxyprogesterone acetate 2.5 to 5 milligrams daily. This is effective in suppressing hot flushes and preventing osteoporosis. Now we have LNG IUS, which releases 10 micrograms LNG per 24 hours as opposed to the regular one that we are using. This protects the endometrium from hyperplasia and cancer. It has no systemic progesterone side effects, and estrogen can be given along with this by any route. Coming to Tibolone, this is a 19-nor testosterone derivative, weakly estrogenic, progestogenic, and androgenic. It prevents osteoporosis, hot flushes, and atrophic changes of the vagina. It is also helpful in increasing libido. But here the endometrium becomes atrophic. The dose is about 2.5 milligrams per day, although there's a slight increased risk of breast cancer and thrombosis. Women should be given informed choice about the relative merits and possible risks of continuing HRT. Monitoring should be done prior to and during HRT. This includes physical examination, including pelvic examination, blood pressure measurements, breast examination, if required, mammography, and cervical cytology. Any irregular bleeding should be investigated thoroughly. As we can see here, there are lots of benefits of almost all the symptoms are relieved with HRT. And as I said earlier, that the dose should be decreased or it should be stopped once the symptoms have improved. But there are HRT is not without risks. There is a risk, endometrial risk, breast neoplasia. Here again, progesterone has no protective effect, unlike the endometrium. There can be ovarian neoplasms, there may be stroke, venous thromboembolism, and there may be a slight risk of coronary heart disease. There are certain contraindications to this therapy: breast cancer, estrogen-sensitive malignant tumors, undiagnosed genital bleeding, untreated endometrial hyperplasia, if there is previous idiopathic or current venous thromboembolism, active liver disease. And of course, there are certain non-pharmacological treatments available. This I will not be touching. Now we should start, there is a concept that we should start HRT early in the menopause for maintenance of estrogenic benefits, and patient selection is important. We should avoid generalized prescribing, and the dose should be tailored to the patient, and continuation and tapering of the dose should occur with age and with her symptoms. As I said, bioidentical hormones are available, but I will not be talking about these. There are various routes of administration that are available besides the oral, and alternative therapies are also available now: selective estrogen receptor modulators, lifestyle management, and phytoestrogens. Now coming to hormone replacement therapy in certain special situations, starting with primary ovarian insufficiency. There's a spectrum of declining ovarian function because of premature decline in the initial follicle number, increase in follicular destruction, poor follicular response to gonadotropins. The sequelae include vasomotor symptoms, urogenital atrophy, osteoporosis and fracture, cardiovascular disease, similar to that seen in natural menopause. So hormone replacement therapy is required in these patients to reduce the risk of osteoporosis, cardiovascular disease, urogenital atrophy, and to improve the quality of life of these women. It is recommended that in contrast to treatment of postmenopausal osteopenia or osteoporosis, low bone mass in women with primary ovarian insufficiency is managed with hormone therapy. We'll be learning more about this in the next talk. These women may experience hot flushes, night sweats, vaginal dryness, dyspareunia, and disordered sleep. The first-line approach in these women is oral or transdermal HRT that achieves replacement of levels of estrogen recommended. Women who desire non-contraceptive estrogen replacement, insertion of LNG-IUS is preferable to oral progesterone therapy. Treatment for all women with primary ovarian insufficiency should continue till the average age of natural menopause is reached. Talking about the risk of breast cancer in these women, there is insufficient data to evaluate the association between hormone replacement therapy or combined hormonal contraceptives administered to women with primary ovarian insufficiency and the risk of developing breast cancer. Women with primary ovarian insufficiency are younger at the time of HRT initiation, and their baseline risk of breast cancer is significantly lower compared to women who are prescribed hormone replacement therapy after natural menopause. Short-term exposure to hormone replacement therapy in BRCA1 and BRCA2 carriers following risk-reducing surgery has not been associated with an increased risk of developing breast cancer. Now, coming to another important aspect, that is hormone replacement therapy after gynecological cancer. About a quarter of women diagnosed with gynecological malignancy are peri or premenopausal. Improvement treatment for these conditions has resulted in more women surviving for longer periods of time. So the quality of life is becoming an important consideration. Combined hormone replacement therapy can be prescribed to women treated for endometrial carcinoma without adverse effects on long-term survival. Hormone replacement therapy should be started soon after surgery is not associated with an increased risk of recurrence. Patients with advanced stage disease do not have an increased incidence of recurrence with hormone replacement therapy. This may also be used safely after uterine leiomyosarcomas, but it is contraindicated in women with endometrial stromal sarcomas. There is no data available on carcinosarcomas. Hormone replacement therapy improves menopausal symptoms in women treated for ovarian carcinoma. Recent data suggests improved outcomes by reducing ovarian carcinoma relapses. Hormone replacement therapy may be prescribed in women who have undergone surgery for germ cell tumors. In case of sex-cord stromal tumors, hormone replacement therapy is relatively contraindicated as they are hormone-related tumors. Mostly the women who have received chemoradiation for cervical cancer should be prescribed combination HRT to avoid the possibility of residual active endometrial cells. And systemic and topical HRT is safe in women who have had vulval cancer. Now, I'd just like to talk about the North American Menopause Society position statement. This is a recent one of 2022. Our own Indian Menopause Society has also given a position statement, which is a little older, but they're basically similar. So HRT remains the most effective treatment for vasomotor symptoms, genitourinary syndrome of the menopause, and has been shown to prevent bone loss and fractures. The risk of HRT depends on the type, dose, duration of use, route of administration, timing of initiation, and whether progesterone has been added. Treatment should be individualized to maximize benefits, minimize risks, with periodic reevaluation of benefits and the risks of continuing therapy. Women aged younger than 60 years and within 10 years of menopause onset without any contraindications, the risk-benefit ratio is favorable for the treatment of bothersome vasomotor symptoms and prevention of bone loss. For women who initiate hormone replacement therapy after 60 years, the benefit-risk ratio is less favorable due to greater absolute risk of coronary heart disease, stroke, venous thromboembolism, and dementia. Longer duration of therapy should be for documented indications, especially persistent bothersome vasomotor symptoms. For bothersome genitourinary syndrome of menopause, symptoms not relieved with over-the-counter therapies, the use of low-dose vaginal estrogen is recommended if there is no contraindication, if there's no indication for the use of systemic hormone therapy. Now, to conclude, the decision for hormone replacement therapy should be made through informed choice by each woman after extensive counseling. The role of counseling cannot be overemphasized. HRT dosage, regimen, and duration should be individualized with annual evaluation. Arbitrary limits should not be fixed on the duration of the usage of HRT. It should be individualized. If symptoms persist, the benefit of HRT generally outweighs the risks. HRT prescribed before the age of 60 has favorable benefit-risk ratio. Women with premature ovarian insufficiency should use HRT at least till the age of menopause. If HRT is prescribed in women over 60, lower doses should be started, preferably with the transdermal route. More research is required on hormonal preparations with maximal benefits and minimal side effects. This will optimize the quality of life and facilitate the primary prevention of long-term condition, mitigating personal, social, and economic burden. I'd just like to add that it's very important counseling, counseling is as important as the prescription, because we find that a lot of women have a lot of misconceptions, especially they go to the social media and they read all kinds of things and they have a lot of misconception. So we need to counsel them, take some time out and counsel them. I wish to thank everyone for their kind attention. Thank you very much for inviting me.
Thank you so much, Himali ma'am. It was really a very exhaustive and elaborate talk on HRT. I think you've covered very nicely right from physiology in depth to its dosage, when to start HRT, in what combination, what duration, when not to give is also equally important. And we have to really, screen out all those patients in whom HRT is really needed and in whom we can do away without oral medications, like you said, transdermal patches or creams can sometimes suffice. Especially the urinary symptoms are much relieved with, I think, estrogen creams only. And a lot of time, patient gets relieved by these creams only. And you've very nicely elaborated and showed us about the recent guidelines also on HRT and their distribution, types and routes and timing, and especially when progesterone is added or and the conditions where progesterone is not added. The various contraindications to HRT highlight was also equally important because we have to really individualize and screen those patients. So it was really a very interesting and exhaustive talk. And as such, we keep saying you are a gem of our society, that is the Patna Obstetric and Gynecological Society. And really, she's really a great academician in true sense. Thank you so much, ma'am, for the talk.
Thank you.
And thank you, Dr. Monica and Public Awareness Committee for the opportunity. Thank you so much.
Thank you, Charu ma'am. Thank you, Pranay sir. And thanks a lot, ma'am, for that, Himali ma'am, for that wonderful and exhaustive talk. We will now move on to our second talk. Our second talk for today is on osteoporosis and menopause. Our speaker for the session is Dr. Jayanto Gupta sir, and our chairpersons are Dr. Rekha Jha ma'am and Dr. Hafizur Rahman sir. Can I have the slides? Yeah. Dr. Rekha Jha ma'am is the president of Bhagalpur Obs-Gynae Society, a very, very active member of the Public Awareness Committee, and she's also the East Zone coordinator. She has been the scientific chairperson of IMA Bhagalpur, past secretary as well as past vice president. Welcome, Rekha ma'am. Our second chairperson is Dr. Hafizur Rahman sir. Sir is the professor of obstetrics and gynecology. He is also the managing ICOG governing council member. He has over 60 scientific research publications in various international and national index journals and has various awards to his credit. Welcome, Dr. Hafizur sir. And heartfelt thanks to Jayanto Gupta sir for accepting the invitation very last minute. I'm so sorry to have informed you last minute. Thank you, sir.
Thank
I
you.
would now request Rekha Jha ma'am or Hafizur sir to kindly introduce Jayanto sir.
Thank you so much, Dr. Satabdi. And I'm thankful to Public Awareness Committee, Priyankur, Dr. Satabdi, and Dr. Monica for inviting me for this valuable CME. So without wasting time, I'd like to talk about Dr. Jayanto Gupta sir. That is, sir is Director and Department of Obstetrics and Gynecology at Apollo Multi-Speciality Hospital, Kolkata. He was also the president of Kolkata Menopause Society, and he has special interest in endoscopic surgery, robotic surgery, urogynecology. And he has been teacher for DNB students as well as guide. He has delivered many guest lectures. So I would like to request Dr. Jayanto Gupta sir to start his presentation on osteoporosis and menopause. Over to you, Dr. Jayanto.
Thank you. Thank you very much, Dr. Hafizur. Is my slide seen?
Yes, sir. It's again loaded, sir.
Thank you. Thank you very much.
Yes, sir.
Right. Today, my talk, as I am in a very short notice, I had to prepare something last night. So it may be very short. I hope it is going to be sweet. Thank you very much, Dr. Charu, and all the rest of the participants. I'm going to talk about menopause and osteoporosis in black and white. No gray shades here. This talk has been prepared jointly by my associate consultant, Dr. Manjeet Mitra, and I give my thanks to her. And I am talking about an iconic film that is called Pather Panchali. This was made by no other than the legendary Satyajit Ray. And this is a scene from Pather Panchali. And you can see two women, one a healthy, youngish woman, and her aunt, the lady. Her name is actually, in the film, it was Indi Thakurun, played by a lady called Charubala. And what does this show? It shows osteoporosis was there. This film was made in 1955. Osteoporosis is there. And osteoporosis will be there until we are aware and make people aware of this dreadful condition. So it is a skeletal disease characterized by reduced bone strength due to deteriorating bone mass, bone microarchitecture, leading to an increased susceptibility to fractures, which can sometimes not only cause morbidity, but mortality as well. So there is a WHO classification as to how do we identify who is going to have osteoporosis or pre-osteoporosis, osteopenia, and how do we do that? By, of course, measuring the bone mineral density. Now, osteopenia, osteoporosis, normal BMD, we measure it by a T-score. And when the T-score is less than 2.5 or below of that of a healthy young individual, then we say that this lady has osteoporosis. And there are definitely some risk factors, one being the age and gender, any previous trauma, medications like corticosteroids. There are women who are on steroids or other medications because of other diseases like SLE, etc. Medical conditions like diabetes and diet that is insufficient in calcium and vitamin D, lifestyle where there is no activity or less exposure to sunlight, and of course some problems or what you call is kind of addictions to smoking, alcohol. They all cause risk factors. These are all risk factors of osteoporosis. And what happens with menopause is the FSH level increases. And recent studies have shown that the loss of bone actually begins during osteoporosis transition due to an increase in circulating FSH, which has actually some action on the bone architecture. Now, here what you see, the effects of estrogen deficiency, especially after menopause and bone loss, are mediated by direct modulation of the three things. There is osteoblast, there is osteoclast, and osteocyte physiology via estrogen receptor on the cell. And here you can see the osteoclasts, which are causing bone resorption. These are osteoblasts, which are causing bone formation. And all of these actually change. And estrogen deficiency is also linked with inflammation, oxidative stress, which further promote the bone loss. Now, how do you identify patients at risk? All individuals over the age of 50 with fracture following even small trauma are at risk. All individuals over 50 with one or more major risk factors for minimal trauma fractures are also at risk. And spinal compression fractures with no history of trauma. So once you have identified people at risk, especially the thin individuals are more at risk rather than the obese individuals. Obese individuals tend to have more even though their weight is more, they tend to have more endogenous estrogen formed because of transformation of androgens into estrone. And how do you check? By DEXA scan, which is dual absorption X-ray absorptiometry. It's a gold standard, and we check it in two sites. One is the lumbar spine and the proximal end of femur. And why is that? Because femoral fractures can definitely cause a lot of morbidity and even mortality. And these can be repeated at 2-year intervals. And this is the type of chart that will be given to you, where the green says that you are all right. The yellow one says that no, you may be osteopenic. And of course, the red one says that yes, you are osteoporotic. So there are other diagnostic tests like quantitative computed tomography, ultrasound, biochemical markers of bone turnover, but all of these are not really in the reach or domain of people like physicians working in smaller towns and centers or even villages. Now, we all know that prevention is better than cure. So what to do? Firstly, we can think of a dietary supplementation, foods that are rich in calcium like milk, chia seeds, sesame seeds, paneer, yogurt, cooked spinach, almonds, amaranth, tofu. These are all rich in calcium. But apart from calcium, you need vitamin D, which can be used as a supplement, or the best is go out and be in the sun and enjoy the weather. So there are also exercises. Before osteoporosis sets in, weight training and high impact activities actually help. But after osteoporosis, resistance training rather than weight training. And also you need your patient to be told to have balance training, because after a certain age, men or women become a little unsteady in their gait and have a higher risk of fall. And if they are osteoporotic, they would definitely have fractures. So this is a small slide. It shows what happens in the bone. There is the osteoblast, one brick at a time, making the bone strong. There is an osteoclast, which is trying to break one bone at a time. This is what that happens during normal times. But when you have osteoporosis, the osteoblast, the bone-forming little guy, is actually putting one brick at a time. But look at the osteoclast. It is trying to destroy the bone microarchitecture and the bone strength by, bursting a dynamite, TNT. So that's what happened in osteoporosis, especially after menopause. Now, what do we have as treatment? We, of course, have the bisphosphonates. It is used for primary prevention of vertebral and non-vertebral fractures at around the age of 50 or more, especially if there is a patient whose BMD shows that she is osteoporotic and needs some kind of a hormonal or other medical treatment for strengthening her bones. But what does it do? It inhibits the osteoclasts, which actually eat away the bone. Alendronate 10 milligram per day or 70 milligram per week is the dosage. Risedronate is also there. Zoledronic acid once a year. All of these are there, but there is a side effect. And once this particular medication is ingested, it is recommended that the patient is not, it should be taken in sitting or standing posture and should not be lying down because of gastric intolerance. There is another thing is when this kind of medicines are used, especially in onco patients, there is risk of osteonecrosis of jaw if taken long term. Then you have the denosumab monoclonal antibody against the Rankine ligand given in subcutaneous route, 60 milligram every 6 months. And there is a side effect, which is hypocalcemia and cellulitis, etc. But most important, what we should be talking about, which is within the realm of the obstetrician gynecologist, all of us, we can think of hormone replacement therapy, which is the estrogen component, which helps with the osteoporosis prevention, and as well as to a certain extent, if started on perimenopausal age. So you can give it oral, transdermal, you can give also tibolone, which when you give, you don't need any progestrogens. And finally, the only side effect of this is vasomotor symptoms, and it is usually very well tolerated. The only thing about tibolone is that the availability is sometimes a question. And once the patients have benefited from tibolone, they would like to continue. And I think it's perfectly safe. Then you have the raloxifene, which is the SERM. It prevents osteoporosis and, of course, breast cancer. But its side effect is that it does cause vasomotor symptoms, sometimes quite severe. and parathyroid hormone like teriparatide, 18-month course for patients who with no response to anti-resorptive therapy, as mentioned before. However, it is very expensive, and there is a daily subcutaneous dosage that has to be done. The next we come to strontium ranelate, 2 grams daily, second-line therapy, but side effect is, of course, thromboembolism and not recommended in case of renal impairment, history of CVA, and ischemic heart disease. And there has been reported drug interaction with tetracyclines and calcium. Now, so what you can do? Of course, you can make people aware of osteoporosis. You can cut down the modifiable risk factors like quitting smoking, that kind of advice, limit alcohol consumption, and give the tips for healthy bones that maintain a regular workout routine, walking, including weight bearing, muscle strengthening exercises. Ask your doctor about bone density screening if you have risk factors and family risk factors. Eat a healthy diet with recommended amount of calcium, vitamin D, and protein, and look forward to preventing osteoporosis. Thank you very much.
Thank you, sir. Can I request the chairpersons to please give their concluding remarks?
Yeah. Thank you so much. I think that was a very comprehensive talk on now, although you mentioned it's black and white, but we got every information in there regarding osteoporosis and menopause. It was very much, I'm sure it will be informative to all the viewers. Thank you so much.
Thank you very much. I thank the chairpersons and I thank the organizers for inviting me. Thank you.
Thank you, sir, for accepting our invitation at the last minute and being there. Thank you, officers, for chairing the session, and Rekha ma'am too. Can we move on to the next academic session, Sahib? Yeah. The next academic session is the panel discussion by none other than Dr. Soumyananda madam and Dr. Madhusmita ma'am. The expert for our panel today is Dr. Abha Rani Sinha ma'am. Yeah. Am I audible? Yeah.
Yes, you're audible.
Yes, ma'am.
I take privilege in introducing Dr. Soumyananda madam. She is an associate professor at Sri Jagannath Medical College, Puri. She is a member of various organizations and has won various quizzes. She also is a research fellow for WHO Action Group 1 and 2 trials, as well as the WHO scopes. But she is currently working in the WHO STEP-MAC trial too. We welcome you, ma'am.
Thank you.
Our next moderator is Dr. Madhusmita ma'am. She's an assistant professor and she's also the clinical secretary of AOGO. She's a research person for PG revision. We welcome you, ma'am. Our expert for the panel today is Abha Rani Sinha madam. She is the principal of the SKMC Muzaffar College, the professor at Muzaffar College, the treasurer of the National Ice Park, and the ICOG Governing Council member of 21 to 23. She has been the president of the Patna OBGYN Society too. We welcome you, ma'am.
Thank you.
Can we have our panelists in this series, please? Dr. Deepamita Banerjee is the chairperson of the Journal Club of Education Committee of the Association Society of Gynecological Oncology. She has been the executive member of the AOGM. She is also the secretary of Oncology Committee of the Bengal OBGYN Society. We welcome you, ma'am. Our next panelist is Dr. Sindhu Bala madam. She is the clinical director of the Creation, the Fertility Center at Siliguri. And she is also the consultant at Arogya Niketan Nursing Home. We welcome you, ma'am. Dr. Joy Sankar Saha is a senior consultant at Railway Hospital, Ranjan, Asansol. He is the ex-HOD at the RK Mission Hospital, as well as an ex-consultant of the same hospital. He has been the immediate secretary of Asansol OBGYN Society. We welcome you, sir. Our next panelist for today is Dr. Queen Aditya. She is the recipient of the APJ Abdul Kalam Award from the Delhi Gynecologist Forum. She is also the member of FOXI, the Perinatology Committee, Breast Committee, and the East Zone Coordinator for Sexual Medicine Committee in the last year. We welcome you, ma'am. Dr. Jayashan Mai Panda is a professor in HOD in Bhubaneswar. She has special interest in preventive oncology and she has many publications to her credit. We welcome you, ma'am. Dr. Professor Sir Archana Kumari Madam is the Secretary of the Ranchi OBGYN Society, the founder Secretary of IFS Jharkhand chapter, and the elected executive member of National ISPA. We welcome you, ma'am. Dr. Pranabika Mohanta is the Assistant Professor, Deputy Superintendent at Assam. She is also the Resource Faculty of the NSC Regional Faculty Development and the Secretary of Jorhat OBGYN Society. We welcome you, ma'am. Our last but not the least, the last panelist is Dr. Simi Kumari Madam. She has done a DNB from Safdarjung Hospital. She is a FOXI Certified Advanced IVF trainee. We welcome you, ma'am. I request the moderators to please take over.
Hello. Actually, the sharing option is not coming, ma'am. So I have already.
Sayan, do you have the PPT ready? You can start sharing for
Yes,
madam.
ma'am. Yes, ma'am.
The share option is coming, but
Ma'am, on the bottom side, there is a green button, share screen. Yes, yes, ma'am. The screen is sharing now. Yes.
yes.
Just double click on the final presentation.
No. I had sent on last AUB that PPT I want.
Ma'am, should I share on your behalf?
Don't send that one. Actually, I have updated on last AUB. That
Yes,
slide on.
last AUB slide. Should I share?
But the name is different here. Abnormal uterine action.
No, but the presentation last AUB I am having.
Okay,
So,
please.
yeah, ma'am.
At the outset, thank you, FOXI Public Awareness Committee, Dr. Monica and Dr. Priyankur for giving us this opportunity. We are honored to be a part of this webinar and I welcome my esteemed panelists.
Hello?
Yeah, ma'am. In just a minute, I will share. Ma'am, hope it will be visible.
Yes, visible.
Yeah. Ma'am, so when I need to move, just say next. I will move to the next slide.
Okay.
Yeah.
Next. So as we know that perimenopause is a transitional period beginning with the first clinical, biological and endocrinological features of approaching menopause, such as vasomotor symptoms, menstrual irregularity, and ends 12 months after the last menstrual period. And the period is variable. It may range from 2 to 6 years. In certain text is written, it may last up to 8 years as well. Next. So as we know, AUB is a common complaint in perimenopausal women, and we have FIGO classification regarding the parameters which should be taken during history taking regarding frequency, duration, regularity, flow volume, and intermenstrual bleeding. And we have the palm point classification of FIGO. Next slide. All of us are aware of the palm point classification. Next. And fibroid is a major cause of AUB in perimenopausal women and is a leading cause of hysterectomy. And we have a subclassification of fibroid according to the FIGO. Next. So this is a classification of FIGO ovulatory disorder. Type 1 hypothalamic, type 2 pituitary, type 3 ovarian, and type 4 PCOS. Next, so coming to our case scenario. So my question to Dr. Deepranita So 47 years old lady, she gave a visit to your OPD with complaints of infrequent menstrual bleeding since last 1 year at an interval of every 2 to 3 months, and her LMP was 3 months back. Duration of flow is 1 to 2 days with 1 pad per day. And on per speculum examination, cervix vagina healthy. On PV examination, cervix is mid-pose, uterus is mid-pose, and pap smear is NILM. Next. So how you're going to classify it according to FIGO? Do we have Dr. Deepanita? Sindhu ma'am, Dr. Sindhu Bala ma'am can answer.
I think this lady is 47-year-old and she is not having heavy periods. She's having infrequent period. So maybe she is going into perimenopausal transition. And since her findings are unremarkable, we just need to reassure her that this can be a part and parcel of perimenopausal transition, which can vary from infrequent period to very scanty period. And maybe it will carry on for another 1 or 2 years till she has a complete cessation of her periods. And we just need to emphasize on the normal transition of perimenopausal period.
Next slide. Yeah, very well taken. So she is having infrequent light irregular menstrual bleeding. Next slide, please. So any investigations you are going to advise her apart from reassurance?
She needs to come for follow-up, and of course I will ask her to get all the hormonal assessment which we do normally, like thyroid assessment, vitamin D assessment, and this is the best time to counsel regarding the importance of preventive therapy which can be taken for prevention of osteoporosis. Get her breast examination done either clinically or by ultrasound, and importance of regular pap smear at least once in 3 years, and once in a year she should come for a gynae checkup, and she should report if it turns out to be heavy or it turns out to be bothersome for her. But this is the best time to counsel against
counseling should be done.
Yeah,
and lifestyle modification as well, and what she is to expect during her menopause.
Yes, and if she has any symptoms coming up, like next visit after 6-month visit, we should counsel for the available therapy also.
She had a menses 3 months back. So is there any role of going for a urine pregnancy test?
Usually academically, for academic purpose we do, but usually it's very rare. Of course, it is not so uncommon. We have seen pregnancy happening at the age of 47 years. I have myself done a DNC at the age of 47 years. So one should do, but ultrasound is normal. So that is another reassuring.
Reproductive age group, UPT is a must for us.
Yeah, yes.
Next slide. Next. Dr. Madhu.
Hello. Ma'am. Yeah. So next scenario is for doctors.
Started.
Jaishankar sir, Dr. Jaishankar sir.
Dr. Jaishankar sir. So a 46-year-old lady came to your OPD with complaint of post-coital bleeding. And when you took the history of pleasure illness, she has apart from that, she's fine, and there is no loss of appetite, no recent weight loss, and menstrual history. It's coming every 28 to 30 days and lasts for 2 to 3 days, and flow is normal. She's prior to leaving to. Other histories are normal. Her LMP was on 2nd of March 2024. Next slide. So what are the differential diagnoses based on the history?
Sir, you are muted. Sir, Jaishankar sir, you are muted.
Sir, I have sent a notification. Hello. Joy sir.
Sir, you have to unmute yourself.
So you're not audible.
We have to ring. We have to.
Can pass this question to Dr. Queen Aditya. And next
Yes,
question we can ask Dr. Jaishankar.
Ma'am, please show the previous slide once, what the exact history was. Just the previous slide once. No.
Postcoital bleeding.
Okay, fine.
No,
So,
scenario.
yes, I've got it. It's a case of postcoital bleeding. Okay, so now the commonest DD that we find are polyp, CIN, and it can be the ominous symptoms of cervical carcinoma as well. These are the commonest, and also in some cases it can be infections.
Yes,
cervical erosion. Cervical erosion is a very common cause for postcoital bleeding.
Yes, ma'am. Rightly said. So after the history, you thought, why not? So you proceed to the examination. And during examination, we got this finding. Next slide.
Next slide, please. Examination findings. I don't see. Polyp. Next.
So on
This
examination,
one. Yeah,
when
we
you
get a polyp.
you did a perspectival examination, you saw a polyp of 2 into 2 centimeter size, and on per vaginal cervix with backward uterus anteverted normally in size and shape. You could see the polyp that's in the cervical polyfusion. And next slide. So ultrasound also was done because you suspected maybe there is some endometrial polyp. So this is the ultrasound picture, and this is a per speculum examination. Uska suppose. So my question is, how do you categorize it according to FIGO? Next slide.
This will be AUBP polyp.
Yes, madam. You're right. So if this patient has come with has a polyp, so how we are going to manage her?
Polyp, a polyp which is easily visible in the endocervical, in the outside the ectocervix, can easily be managed by simple polypectomy. Any detailed procedure is not required. Simple polypectomy in this case is sufficient. But along with that, I will still go for later. I will go for a pap smear.
Yes, madam. So
we have one problem does not mean that there is not another problem. So pap smear we cannot evade, that we have to do. But here we can see a simple polyp, that there are two existing conditions will be rare. So first we do the polypectomy, and when the bleeding stops and all, then we can go for a pap smear as well.
So would you go for any endometrial biopsy in this case?
Yes, because actually what happens is there can be coexisting polyps as well, endometrial polyps. And if we ultrasound, the PV that we are doing, if that is showing any thickened endometrium, that can sometimes, the polyps can be falsely seen as just a thickened endometrium. So in any perimenopausal age group, when there is bleeding, there is no harm in doing any kind of an endometrial biopsy. So as far as I am concerned, I will do in any case that comes with, a thick endometrium and irregular bleeding, along with, these kind of symptoms, I will go for an endometrial biopsy in the perimenopausal age group.
Yes, sir. So, madam, you'll do even if endometrium is normal. In this case, endometrium is only 6 centimeter. But
no. Thick endometrium, at least 10 millimeters or more, then I will go for it.
Yes, ma'am. So, ma'am, next question. So, madam.
Next. So this question is to Dr. Jaishankar Saha. A 46 years old perimenopausal lady came with complaints of intermenstrual bleeding to your OPD. Her cycles are for 2 to 3 days duration every 38 to 40 days, and she uses 1 to 2 pads per day. Previous cycles are normal, and her LMP is on 8th of March 2024. She is para 3, living 3, and on per speculum examination, cervix vagina healthy, and on PV, cervix is backward, uterus anteverted, normal in size and shape. Next. So how will you categorize it according to FIGO system 1? So you're not audible.
Ma'am, I have one suggestion, please. When you are putting up this question, according to FIGO system 1, kindly show the previous, because it is not possible to remember all of those details. Seeing
Sure,
them, we can
sure.
directly
madam.
say.
Show the
Yes, yes.
previous slide.
Uh-huh.
Cycles are 2 to 3 days every 38 to 40 days. She used 1
Shortest,
to 2 pads per day.
means from shortest to longest cycle variation is 38 to 40 days only, madam.
There is
And
complaint of intermenstrual bleeding.
and that also randomly she is complaining, madam.
So irregular, cycle is irregular or infrequent also. We can see it is infrequent.
Yeah, next slide. Sir, will you be able to answer?
Irregular, infrequent. It is something like that.
Dr. Pranavika, please answer.
Yeah, hello.
Hello.
Yeah, it is actually intermenstrual bleed is there. So it's although it's coming at it's not heavy, it's light, and it is regular because it is coming at 38 to 40 days. But she has intermenstrual bleed, so she will be in the intermenstrual bleed. We will have that pathology in her.
Next slide, please. Infrequent irregular menstrual bleeding with random menstrual bleeding.
Regular.
Next slide. So we did a ultrasound and this is the ultrasound image. So what is your differential diagnosis?
One is your endometrial hyperplasia. If we see a regular, we can see hyperplasia, regular hyperplasia. But yes, we have to rule out a polyp also. It can be a large polyp also. But more or less, it looks like endometrial hyperplasia.
What other investigation you should advise for confirming the diagnosis?
Yeah, we can go for a. This is a good quality only ultrasound. If we can just infuse saline, just to see whether it is like polyp or endometrial hyperplasia, whether it is irregular or not present. So if it is, we can see a space of population, it's polyp. If it is compressed, the endometrium is compressed, then we'll see it is uniformly compressed, then maybe it is hyperplasia.
Next slide. Next. Diagnostic accuracy of saline infusion sonography equals the accuracy of diagnostic hysteroscopy. So any one will suffice. Next. So what is the advantage of saline infusion sonography over hysteroscopy?
It's less painful.
Yeah,
It can be done in the recovery. It is usually done by the radiologist.
But there are certain advantage of hysteroscopy as well.
Yes. We can, we can have the biopsy as well by looking at the endometrium. We can see some pathology in the endometrium. That is like hysteroscopy is like gold standard. If we have endometrial hyperplasia, we want to take biopsy also.
Next slide. The biopsy can be taken in the same sitting, and in this office hysteroscopy, it is less painful to the patient as well. Next.
Can I add, Soumya?
Sure, ma'am. Your expert.
Okay.
Very much required.
Okay. So the discussion is going on very well, and you have rightly pointed out for small polyps, we can miss on an ultrasound, but if it is a good 3D ultrasound, we can pick it up. But for saline SIS, the only disadvantage is that we cannot be able to take a biopsy.
Yes.
So if we have to take a biopsy, a hysteroscopy is the answer. But of course, as you rightly said, SIS gives less discomfort to the patient, and we can just combine it with our ultrasound also. So just I wanted to add these comments. Thank you.
Thank you, ma'am. So what is the category according to FIGO system 2?
It will be AUBM or P if it is a polyp. So mostly it looks
polyp,
like
it will be AUBP.
Yeah.
Next slide.
Ma'am, we can ask ma'am how are you going to manage this case? This came as a endometrial polyp.
Polyp, we can go for polypectomy, hysteroscopy guided like resectoscope. You can just take it out. Or if it is endometrial hyperplasia, I will go for endometrial biopsy, and we can just put a LNG Mirena inside. If it is hyperplasia, if it is a polyp, then obviously we have to take it out.
So suppose a polyp is there and you remove
ना
hysteroscopy
मेरा
guided.
सेमिनार चल रहा है बोलो
Hysteroscopy
हेलो
guided, you remove the
सेमिनार चल
polyp.
रहा
So simultaneously you go for endo
है बोलो
biopsy or not, or simply you will remove
Yes,
the
yes,
polyp.
of course. Yes. I will go for endometrial biopsy
फोन
also
अटेंड
because
करो
I can see the endometrium. You can take fractional biopsy in the hysteroscopy
सेमिनार चल
sensitive.
रहा है
But it will depend on the size of the polyp. If the polyp size is bigger, I cannot take it in the same setting. If I need a second setting for this, then probably then in the next setting I will be taking the biopsy.
Okay. Thank you. Well said. So next question will be for Dr.
Dr. Deepanvita.
Dr. Deepanvita.
Yeah.
Next
So,
slide, please.
before
Next
going
slide.
on to the next question, I just have a query. Abha ma'am, good evening. So
Good
do we
evening.
do SIS nowadays for endometrial hyperplasia or
Not for hypoplasia, Deepanvita. I was talking about polyps.
regarding
But
the polyps we
with
can go
good
for?
3D ultrasound, we don't need to do an SIS. That was the first point that I had said. That was the first point I said. But if in a low resource setting, if at all you're doing it, you're not able to take a biopsy. That was my
Yeah. That's
yeah.
what. Like
That was my point.
Yeah. So we can go ahead with hysteroscopy biopsy, do the polypectomy
Yeah.
at same sitting, and because SIS, then again you can't take a biopsy. It will add cost.
Sure. Yeah.
It
That
will add
was the
cost.
point I had emphasized. Yeah.
Yes. I heard
That's
that.
what
Okay.
Still in low
Sorry, I
resource
joined late. I was
setting.
driving back
No,
home. So,
Good that Deepanvita, you are there. We'll get some excellent inputs from you.
Hopefully
Next,
I will
Next
be able
question,
to
Dr. Deepanvita.
Next question for
Yeah,
Dr.
good
Deepanvita
evening.
only. So a 47-year-old lady came with complaint of heavy menstrual bleeding and she is having this since 1 year. So when you inquired, she tells like it's coming at an interval of 60 to 90 days and lasts for 10 to 12 days. She's soaking 7 to 8 pads per day. It's associated with clot also, but no dysmenorrhea. On menstrual, the previous cycles are normal before 1 year. And her last menstrual period is 29th of February 2024. Other history are all normal, no issues. And when next slide. When you did a per speculum exam, so you saw that cervix and vagina are healthy, and on per vaginal exam, the cervix backward, uterus anteverted, normal in size and shape. So next slide. So how do you classify according to FIGO system 1?
Yeah, so FIGO system 1, FIGO system, this will be a heavy menstrual bleeding.
Yeah.
Infrequent, irregular, heavy menstrual bleeding, as far as my understanding.
Yes. She's definitely having heavy menstrual bleeding. Along
Yeah.
with that, she's having prolonged menstrual bleeding because it's lasting for 10 to 12 days. And definitely you're right, it is infrequent.
It's
In heavy,
frequent.
prolonged, infrequent. Along with that, it's irregular because a variation between shortest to longest cycle is more than 9 days in
9
this
days.
age group.
9 days.
So well said. And next question.
Because we used to learn regarding this menorrhagia, metrorrhagia. So this terminology is now out of date as far as my understanding. So, so I'm quite old now. So it is the new FIGO system classification which we have to go through. This is the system 2 comes under the palm coin, right? Palm coin.
Yeah.
That is a very nice article regarding this, recently published only 2023.
Yes.
So my next question. So how you are going to investigate her? So what are the investigators you're going to send?
Yeah. So she is a perimenopausal woman with heavy menstrual bleeding with infrequent cycles. So first of all, I will like to elaborate on her history, whether she is taking any oral contraceptive pills or hormone replacement therapy or not. Then regarding her clinical evaluation with her all this background, I will definitely would like to go for a clinical proper examination, taking a cytology, as you rightly mentioned, and a thorough clinical speculum examination along with the TVS pelvis in OPD setup itself, if it is available, to see the endometrial thickness. So that will be my first to approach towards this case. And of course, the endocervix, if there is any polyp or any thickness or any growth, so that also we have to evaluate. So that will
I
be
will
my
add thyroid examination as well. I'll add thyroid examination as well.
thyroid, yes, of course, thyroid examination. So means in clinical history.
Thyroid and CBC, I think these are the two that we cannot miss.
Hi, Quindy. Yes.
Thyroid, TSH and CBC, I think these two we cannot miss.
Dipanvita, I have a query. Like in a premenopausal patient, does the endometrial thickness matter that much?
No, ma'am, it just gives us idea, no?
No, she is a perimenopausal. Yes, she is a
very
perimenopausal.
important
47.
that when to take the endometrial biopsy. Like immediately post periods, we expect a thin endometrium, and at that time, if we are getting a thick endometrium, then that should raise suspicion. Or if the patient is on progesterone, then in that case also we may get a thick endometrium. So taking hormones, all this history is important. Though we get a suspicion about endometrial thickness, seeing the endometrial thickness, some sinister thing, but actually in premenopausal women, endometrial thickness is not a very important finding.
Yes,
but we have to rule out polyp. I think this message should go that for premenopausal women, endometrial thickness, there is no particular cutoff.
No, absolutely not.
You
So
agree?
the endometrial thickness cutoff more than 4 millimeter is applied for the postmenopausal women.
Postmenopausal women, yes.
Postmenopausal women only.
So endometrial thickness, here we have to look at the irregular endometrial thickness. It could be a polyp, or we have to time our endometrial thickness with the timing of the menstrual cycle, like in the immediate post-menstrual phase. Accordingly, we should interpret the endometrial thickness.
Oh, yes. So postmenopausal women, of course, but if a perimenopausal woman, it is thick with irregularities, and there is
then
some
it is important.
structure. So it will give us some kind of idea. If it is available in PD basis, it's okay. Otherwise, just means it's a baseline investigation which you have to evaluate. But definitely for the postmenopausal women or perimenopausal women, we do prefer it. For menopausal, there is not much value.
Yes.
Okay, so next question will be for next panelist.
Do we have Dr. Joshna ma'am with us? Dr. Archana Kumari? Dr. Simi? So question again for Dr. Sindhu ma'am.
Yes.
Ma'am. Question is actually next before above one slide. Actually, we did an ultrasound.
Yes.
Previously,
may I see the film?
So actually, pap smear was done. That was normal. Hemoglobin C is moderately anemic. Ultrasound was done. That was normal. Endometrial thickness also normal. So would you go for endometrial biopsy in this case or not? If yes, what?
I follow what after 40 years, I usually go for a hysteroscopic guided biopsy, because many a times I have seen very tiny polyps which we are missing. Sometimes, as Dr. Abha ma'am has already suggested, endometrial thickness and endometrial ultrasound does not correlate in premenopausal women. So when we did ultrasound, she might be just in a post period phase, post menstrual phase. And if we do ultrasound in a later phase, like secretory phase, or after 20 days or 30 days of periods, we might find some endometrial polyp. Sometimes even, endometrium get hyperplastic and it folds on itself. that causes temporary polyp formation. We have seen many a times when we prepare endometrium for the embryo transfer. So I will go for hysteroscopic guided biopsy because that is the gold standard. I myself, I am not very convenient and very comfortable with pupil biopsy. People wants to get comfortable anesthesia and comfortable procedure. We do as a daycare procedure, we do hysteroscopic guided biopsy. And here we get an opportunity to examine the uterine cavity, and we can take a biopsy, and we have an opportunity to get the histopathology report as well, which could be, you know, simple hyperplasia or complex or atypical. That will help us in, you know, deciding further therapy, whether she needs psychological progesterone or something else.
Definitely hysteroscopy is gold standard. That is the right answer. But the thing is, it's not available in all the setup.
Yeah,
Because
if we do not have, then we can go for the lesser variant, that is a pupil biopsy, which is an office biopsy thing. Most of the time, it gives enough sample to have a histopathology report in our hand. But it cannot give the anatomic variation like minor endometrial polyp or any submucous polyp or any minor growth.
Next slide. So actually, this I took from a talk article. It's a nice article, and they have right from recent one. So what they have found that pupil biopsy sensitivity is 90 to 100%, and in case of hysteroscopy, 86.4%, and specificity if that of pupil is 98 to 100%, and hysteroscopy also 99.2%. Failure is more in case of pupil biopsy. Next slide. And there was a published article in BJOG. So what they felt, somebody who is having heavy menstrual bleeding in perimenopausal, so they have done biopsy and it came on no malignancy, 30% reassured. But again, 4.5% developed endometrial cancer. So next slide. So definitely, as our gold standard history, no doubt it is a gold standard, and we should definitely go for that. But as I told, many of the setup in our Indian setup, it's not available. So in those cases, what from this one nice one very good article, what they have told, women with benign or inconclusive histology but persistent symptoms or suspicious ultrasound finding should be offered hysteroscopy. So they are again segregating.
That's very true.
So if I may add something.
Yes, why not?
Yeah, so I think so there are some specific indications that when we will do pupil biopsy on OPD basis and when we will do a hysteroscopy guided biopsy. So like if it's a focal lesion, first that's why if we do a OPD in OPD basis, we are doing a TVS pelvis, assessing the endometrial thickness, any structural abnormality like polyp or endocervical growth. If it is amenable for a biopsy, then and there you can offer her a biopsy in OPD basis itself. Like any cervical growth or endocervical growth, if it is possible to take a curettage, or a polyp, for if the endometrium is diffusely heterogeneous, it's irregular throughout the endometrium, then you can go ahead and do a pupil biopsy. Then and there, on that same sitting, you can offer her a pupil biopsy. And it's a very non-invasive, minimally invasive, I would say, it's a minimally invasive procedure. The diameter is 2.5. It's very, very thin and long. Either you can do a you can use a Karman's cannula or a pill biopsy, endometrial aspiration. And for hysteroscopy is more applicable for focal polyp, endometrial polyp, or there is any focal abnormality of the endometrium. So there we can go ahead with hysteroscopy biopsy. So for particularly this case, hysteroscopy guided is the gold standard. But as you mentioned, that it is always not available or not, like it requires a daycare procedure. So that be like for case, the approach can be like that. If it's doing a TVS as baseline, if there is any abnormality, then and there you go for a pupil biopsy, and if not, if there is any focal lesion, you put her up for hysteroscopy biopsy. Yeah, Abha ma'am, I think wants to say something.
I totally agree with Dipanvita, what you have said. One point I would just like to add that even if we get a negative finding on a pupil biopsy, and if the women has persistent or recurrent bleeding, always do a hysteroscopy directed biopsy. Because what happens with papillae, at least half of the,
Your
whenever we
voice, it's not audible.
is it audible now?
Yes, ma'am.
Yes. So I just wanted to say that whenever you are getting a negative papillae biopsy, and if the women is bleeding persistently or recurrent bleeding, then you should always do a hysteroscopy directed biopsy.
Yes.
That is an indication for a hysteroscopy directed biopsy. And the other point is that whenever we are doing a papillae biopsy, at least more than half of the endometrium has to be involved. So as you rightly said that it is for diffuse lesions. If it is a global lesion or a local lesion, then hysteroscopy is only going to work. In those cases, papillae biopsy will not give us a reliable result.
Yeah, the failure rate will be high.
Failure rate will be very high.
Yeah.
Yes.
False negative rates will be high.
Okay,
Yeah.
thank you.
Yeah. So next slide. We did a endometrial biopsy and it came as there is no malignant changes. Next slide. So according to FIGO system 2, how you are going to categorize it?
I think we have to show the history, menstrual history of the patient.
Show the menstrual.
Previous slide, please. Previous.
ये बहुत tough question है.
Actually, according to system, we have already classified her.
इससे तो आप OT करा दो हमसे, लेकिन इससे मत पूछो.
Now, FIGO system 2 classification. System 1, Dr. Dipanvita had answered correctly.
Yes.
Sindhu ma'am, what will be the FIGO system 2 classification? Palm point.
Heavy menstrual bleeding, and I think it will come under coin.
Yes.
Very nice.
Next, endometrial and ovulatory. Next.
So my question is to next panelist.
Jai Shankar sir. Next.
Investigation we did already. We have histopathology report.
Treatment.
This patient, because this patient, though he came with heavy menstrual bleeding and this prolonged menstruation, all investigation we did. There was pap smear also normal, ultrasound findings normal, endometrial biopsy, no malignant changes. So how we are going to manage her?
Correct anemia and give LNGIUS.
May I answer?
Yeah, yes, why not?
Madhushmita, 1 minute. Maybe you are saying there is no malignancy. Probably you will all have to mention that there is no hyperplasia also. It is just a normal finding, right?
Normal.
Ultrasound, madam.
Neither malignancy nor hyperplasia. Nothing is there, right?
In endometrial
No
biopsy.
hyperplasia. Endometrial biopsy, no malignancy. Ultrasound, ET was normal, madam.
Hyperplasia also.
Okay.
No hyperplasia also. It's
Yes,
like
ma'am.
normal. Yeah. So first thing
So
we have to
normal
correct her anemia. She may be, a case of anovulatory bleeding, as I said, coin, because her periods are infrequent, and it's just having she's having periods due to hormonal breakthrough bleeding. So first we have to correct her anemia. That is very important, and we have to give her some antifibrinolytic agents and NSAIDs, the combination of PAUSE, MF, tranexamic acid, and meftal-spas during her periods, to decrease the amount of bleeding during her menstrual loss, which is quite heavy and quite prolonged. Then the duration has to be shortened because she bleeds usually for 10 to 12 days, which is really heavy. So we should start some hormonal replacement in the form of regular progesterone tablet, starting from the 5th day of the period, and should continue at least 20 days. If she is comfortable with oral progesterones, we can combine 10 milligram tablet twice daily for 20 days, starting from 5th day of the period. If she's not comfortable in taking, because many people are very forgetful and they tend to forget the tablets. Once period stops, when bleeding stops, they stop taking the tablet, and this causes another problem. So in those patients, we can offer her the choice of LNG 20, which is very good and very I'll say it is as effective as hysterectomy, because patients usually are benefited and they are, they are protected from taking tablets daily, remembering, and systemic side effects are also associated with the oral progestins. We all know the patient feel puffy and bloated and lots of symptoms. So LNG20 is one option. Second is oral progestins and anemia treatment and antifibrillary treatment. We have to combine them. We should educate enough so that she doesn't forget to take the medicines. Otherwise, she'll say कि आपने ठीक से treatment नहीं किया. If she is not comfortable in taking tablet, we can counsel her to go for LNG20.
Very well said, madam. Well said, madam. Very right answer. But now patient is telling, I'm fed up with this heavy menses. Please do a hysterectomy for me. So what will do?
Yeah,
I
we
can't.
are.
I can't
We
like
have
this.
to respect their choice, but now we are in the category of those doctors who are like preserving the uterus more rather than getting rid of it more. So I always emphasize, you first try it. If it doesn't suit you or you do not like it, or if you have any problem, I'm ready to listen to you. But first listen to me and, follow one of these treatment. And usually patient listen. Nobody wants to undergo knife, because every surgery has some or other side effects. It's if we can offer something non-surgical, it is always better.
Yes. So we'll tell her the risk of
hysterectomy audit as well.
Yeah.
Hysterectomy audit for unindicated hysterectomies. So
We do not do.
do.
unless until like she is getting so anemic that she is coming with 4 gram or 5 gram and she's not accepting any treatment. She's so stubborn. Only then.
She's also 47 years old, so we can also, like, after some time, she might
Yeah,
get
you will
menopause.
have-
Stop only. Yes.
Yeah.
Thank you. So our next scenario over to Soumya, madam.
Next slide, please. Next. So next question to Queen ma'am. A 46 years old lady came to our OPD with complaints of heavy menstrual bleeding for 1 year. She is bleeding 8 to 10 days every 21 to 30 days, soaking 7 to 8 pads per day with associated clots. Previous menstrual cycles, she had periods for 3 to 4 days every 28 to 30 days. LMT is on 2nd of March, not associated with clot. Her BMI is 30. And on per speculum examination, cervix, vagina are healthy, and on PV examination, cervix is backward, uterus anteverted, normal in size and shape. Next.
The most important, her BMI is 30 kg per meter. She is not obese.
BMI is
30.
30. Previous slide. Once
Classify
again,
according to figure.
Yeah, just 1
Next.
minute. No, but we don't have the investigations yet. Now, how can I? Figure 1. Okay, that will be. Yeah, figure 1 will be heavy bleeding. Then it will, just a minute. It will be regular. No, it's 21 to 30 days, so it will be regular, but it will be prolonged because more than 8 or more than 8 days. So prolonged and heavy and regular. It will be that way.
Next slide, please. Next. Heavy
prolonged.
Irregular because the range is 21. So if it is less than 24 days, yeah. Less
What
than
is the
24, it becomes
More than
regular.
9 days.
21. Ma'am, please go to the previous one. It's very confusing. The previous one, once again. The previous one. So 21 to 30, yeah. Less than 24, it will be, it can be that is frequent. Irregular, that will be frequent category. If infrequent is more than 38 and less than 24 is the frequent. So it can be the frequent to regular, like 21. If it's 21, it's frequent. If it's 24, then it's regular. So it's that category, and heavy and prolonged because it's more than 8 days. Yeah.
Next.
Yeah, okay.
Next slide, please. Next. So can we start treatment before we start investigating her?
Ma'am, when a patient of this category is coming to us with heavy menstrual bleeding, she will land up in severe anemia apart from getting psychologically totally disturbed. So we will have to do both parallelly. We will have to start her on medication to stop the bleeding, and at the same time, we will have to start investigating her.
Yeah, definitely. Next slide, please. So according to NICE guidelines, we should start pharmacological treatment for heavy menstrual bleeding without investigating the cause if the woman's history and/or examination suggests a low-risk fibroid, uterine cavity abnormality, histological abnormality, or adenomyosis, and subsequently will go for investigation. After
Yes, we'll have to
initiating the
find that
treatment.
out.
Yeah.
We will start around, as Dr. Sindhu had mentioned, tranexamic acid and progesterone. We'll have to start around a heavy dose of progesterone to stop the bleeding, because these people are fed up. When they come to us, they come crying that we can't take it anymore. So we might have to start with a higher dose and start, like, whether it's medroxyprogesterone or norethistron, we start with a higher dose along with tranexamic acid.
Which is your preferred progesterone?
I personally use norethistron more.
Yeah, it has better styptic action, definitely. Next slide. So what investigation you'll plan to reach?
Yes, ma'am. Hello, can you hear me? Yeah. So personally, I use norethistron more than medroxyprogesterone, but probably, I don't know why, 70-30. I use more of norethistron and also medroxyprogesterone in some cases. But you see, in norethistron, with the 5 milligram preparation, we can taper the dose gradually. So that gives one advantage. So if we start with, in some cases, 6 tablets per day, then gradually we can go down in severe cases. And that's why I prefer going for norethistron more.
Norethistron, it has definitely better styptic action than medroxyprogesterone.
And also, ma'am, gradually we can, from the higher dose, we can go to the lower dose. So that is also, as the patient is improving, you can gradually, step down also. Yes.
What investigation you will go for?
Now, at the very beginning, CBC and a TSH, as we have already mentioned. Then the first thing is a TVS. If like a TVS, a pelvic ultrasound, and in most of the cases, in these kind of cases, after assessing the endometrial thickness, as Abha ma'am has said, that probably in many of these cases, they're already on progesterone or whatever. We cannot be very sure from seeing the exact thickness whether we need. But in most of these cases, I personally will go in for a biopsy as well, an endometrial sampling.
Yes.
That is very
definitely.
The ultrasound
will do a thyroid profile as well.
That I mentioned at the beginning, ma'am, CBC and TSH, right at the beginning. That's the rule of the thumb. And then the ultrasound, and then the palm, or all of those palm, we will be able to find out from here. And if the thickness is on the higher side, I will go for an endometrial sampling as well. If not an immediate hysteroscopy, but at least an endometrial sampling.
Next slide. What are the differential diagnoses?
So that depends on what we get from the ultrasound. So it can be PALM, PALM, any of those we can get. And in all of these cases, when the bleeding stops, we go for a PAP, as we mentioned earlier also. While she's in the acute bleeding phase, there's no point. Once that is over, because we have to rule out some cervical pathology as well. So that is also required at some stage, if not immediately.
When should we take the PAP smear?
After the bleeding stops, not during the bleeding is there, then anyways we will not get any conclusive report. So once the bleeding is done with, after we put her on progesterones and all, once the bleeding is controlled, then only we will go for a PAPS.
Yes, ma'am. Next slide. So this is the ultrasound image of the lady. Endometrial thickness is 16 millimeter and bilateral ovaries are normal.
So this looks like AUBM. That is hyperplasia of malignancy, that category.
Yes, you have correctly categorized. Next slide, please. Next, ma'am has already answered. Next. So what will be your further management for this patient?
First of all, we'll have to do the endometrial biopsy. That is the first thing that we need to see whether it's a hyperplasia or a malignancy, if hyperplasia with or without atypia. So these are the things.
Endometrial biopsy comes to be hyperplasia without atypia.
Next slide.
Next slide. Next.
If it's hyperplasia without, because earlier we used to say simple and complex and all those are obsolete now.
Obsolete.
it is only hyperplasia with or without atypia. So if it's hyperplasia without atypia, less than 5% of cases actually progress to malignancy in a span of over 20 years. So less than 5%. First of all, we have to, because the moment we tell them there is some disease in your biopsy, they get very panicked. So we have to, first of all, reassure to some extent that the possibility that you will land up in a cancer or carcinoma is very low. And after that, we have to start in many patients after counseling, they don't want to go for any kind of treatment, and only observation in cases of hyperplasia without atypia can also work. But we usually ask them to go for medication, which is usually progesterone. And the better one is the liver, LNG-IUS. And if not, then oral progesterone. But that is the
LNG-IUS is the first line management for endometrial hyperplasia without atypia. Next slide. And second line is oral progesterone, as you have rightly mentioned. Next slide, please. So this also you have mentioned that the risk is very less than 5% over 20 years. So that the endometrial hyperplasia is going to progress into endometrial CN. Next slide, please.
Ma'am, we have to reassure them and counsel them also, because as soon as they hear that there is a disease, their friends will tell them, oh, that person had a cancer, this, that, and the other. So the possibility in your case is very low. That also we have to counsel and reassure them.
I think we have Dr. Simi with us now. Dr. Simi. So the next question is that how we are going to follow up a case of endometrial, previous slide. How we are going to follow up a case of endometrial hyperplasia without atypia.
Ma'am, then
once we are oral progestogens. So how frequently you are going to monitor her or follow up?
At least once every 6 months. So until 2 of them we find a negative sampling, then we go yearly. Sampling is to be done. We have
certain cases, if the BMI is more than 35, so in this case we have seen the BMI is 30. So if BMI is more than 35, then after 2 negative consecutive endometrial biopsy at 6 months interval, we do annual endometrial biopsy.
Annual, the same. Yeah.
So next slide, please. So what is the role of endometrial ablation in?
Yes, ma'am. Actually, ablation can seem very lucrative to many people, that, you know, like we are going for an LNG-IUS, why not go for an ablation? But the thing is that we have to follow up also. And so after ablation, the possibility of synecdoche becomes very high. So following up by an endometrial sample later becomes very difficult. Moreover, ablation might not ablate the entire endometrium. Some of it might get, still remain. And moreover, if there is synecdoche, we miss out that. And if that progresses to atypia or further, then we will land up in soup. So endometrial ablation is not a good idea in cases of hyperplasia.
Very rightly said. Next slide, please. So it's not recommended according to RCOG for treatment of endometrial hyperplasia because of complete and persistent endometrial destruction cannot be ensured, and intrauterine adhesion formation may preclude future endometrial histological surveillance. But it was a fad few years back, and I have also done many cases of endometrial biopsy few years back. But so now and present times, it has no role. Next,
Can I add one point?
Sure.
Just not this, the previous question. Actually, when we'll be putting this LNG-IUC, this patient is having BMI 30 kg per meter square. So 2 endometrial biopsy will do 6 interval. So if that is negative, then we can discharge her. Means no need of any follow-up. But when BMI will be more than 35, then rightly you said, after 6 months, next yearly follow-up will be there. And another possibilities are there. She might not, she will have persistently that endometrial hyperplasia will be there. So in those cases, we might go for surgery. Total abdominal hysterectomy you have to choose.
Yes, if there is no regression, and
possibly,
persistent, then we have to go for surgery.
or it might convert to hyperplasia with atypia. So in those cases also will go. So actually this is according to RCA, the flow chart just I was telling.
Yes, so if it progresses to atypia, then the treatment will change. Now we were only in the hyperplasia without atypia category. If that
Yeah.
goes to atypia, then our first preference will be going for a hysterectomy. Now only those patients who are persistent, who want to preserve the uterus, only in those cases, the question of follow-up and all of that is coming every 3 months and all. But in those who do not desire to preserve the uterus, the best option is to remove the uterus.
Yes. Ma'am.
In case
Kindly
of with
continue.
atypia.
Next slide, please. So on follow-up, if the histopathology is endometrial hyperplasia with atypia, so what are her options? Josna, ma'am?
The best option is hysterectomy,
Yes,
ma'am.
so already told hysterectomy is the option because with atypia means we may miss also endometrial carcinoma in some case of endometrial biopsy. So always we should be in the side of hysterectomy while counseling these patients. So my take is on hysterectomy, but if the patient is so keen to preserve her uterus, then we can follow up and also we can give the LNG, IUCD or progesterone. But while counseling, we should be in the side of hysterectomy always.
So if she is not keen for hysterectomy, how frequently should we follow up?
3 months.
Yeah, 3 months.
3 months.
This
Yeah.
with atypia.
And
Next
always
slide.
it should be with a hysteroscopy guided biopsy, not that a
Guided
BPL or anything. Yeah.
Next slide, please. Next slide. So what about bilateral salpingectomy along with hysterectomy? Do you prefer doing bilateral salpingectomy in all the cases?
Whether you will remove ovaries?
Salpingectomy always we do.
Yeah. What
And
about
what
ovaries?
about ovaries?
Ovaries, it should be, it varies from person to person, and it is counseled, and if you everything is normal and there is no familial history, nothing, both ovaries are looking normal and they are ensured that they can come to follow up also, then only we preserve the ovaries. Otherwise, it should be counseled again, depends upon the age and the history, and as you said, this is obesity also there, and whether she was any infertile treatment, all the history will take, which should not be any chance that there is more chance of ovarian carcinoma. Then only we can preserve the ovaries, and they should be always come to follow.
It depends on age also. If she is nearing
Yes,
menopause, there is
yes,
no point in
it's
preserving for
not
one of
that. Here the age is I think 47. It is
47.
perimenopausal. It's not menopause, perimenopausal woman. So we can preserve the ovaries, can. But while counseling, again, this is a gray area where the patient is not sure that she will come for follow-up. Then also we think of because the ovarian cancer also is in rising trend. So we should think of that also. Because she thinks that I have removed the uterus and she goes into menopause. So she may neglect for coming up a follow-up for her ovaries. She may forget about her ovaries also. So that's also we should keep in your mind, because we are seeing many cases of ovarian cancer in this type of preserved ovaries.
Sindhu ma'am, what is your cutoff for removing, age cutoff for removing ovaries?
I usually counsel above 45, but if patient prefers not to remove it, I usually do not do. Patient
Yes,
consent must, because I have to emphasize, if I'm removing
Yes.
before 50, after 50, I usually suggest. That time I do not counsel in favor of preserving. 45 to 50 is a gray zone. Before 45, I usually
Yes.
do not remove.
Yes,
45 to 50 is a gray zone.
Yeah.
And if patient wants to take HRT and wants to come for the follow-up, regular follow-up, I will not remove. I might not remove if she desires to preserve the ovary. But if she says, I please, most of the patient says like that, sab kuch nikal dijiye. मुझे कोई भी कैंसर का रिस्क नहीं चाहिए. In that case, I take it out, but I usually ask them to get HRT, and I emphasize on that. So 45 is my age.
Here we do not remove ovaries in 45 age, but always you can counsel according to the evidence how much. In general population, it is around 4 to 5%. So that's why hysterectomy with salpingectomy always we do. And if the both ovaries are looking normal and there is no high risk of getting a ovarian cancer, then we can counsel about the preservation of ovaries. 45, we don't think 50 is our.
We usually remove
Yes.
after 50 years.
After 50, we are in the side of removing, and while counseling, because they depend upon our only what we say. So while counseling, we should give option to them, but simultaneously we should give them the scenario what is happening nowadays, because ovaries they also need for screening like ultrasound. They should come for that.
Now many
That is
women
again.
are coming with late menopausal as well. They are attaining
Yes.
menopause around 54, 55 years of age.
Yes, yes. Yes, many people are there also so much about this menopausal symptoms, and they are somewhere they are counseled about they are also aware of that also. So taking the positive, it varies from person to person. We have to see all the patient as a whole. What is your scenario? Then only we can decide.
Next slide, please. Next slide. So as correctly said, incidence of CA ovary in general population is 0.4%, and those who are BRCA1 positive, they have a higher risk, 37 to 46%, and BRCA2 positive, 10 to 27%. Next.
Again, this you see this 0.4%. Can we say it as a low percent or high? High incidence or low incidence, that also matters. 0.4, I don't think it is a very low also.
High.
Yeah, yes.
Next
4
slide.
in 1000 means that is not.
So next case scenario for Dr. Pranavika, a 47 years old lady complains of heavy menstrual bleeding for 8 months, dysmenorrhea during menses. She uses 6 to 7 pads per day. Menses last for 7 to 8 days, and variation between shortest to longest cycles more than 9 days. Previous cycles were regular. Next. So on examination, per speculum, cervix, vagina healthy, and on PV examination, cervix is backward, uterus anteverted, 10-week size, firm in consistency, and mobile. Next. How will you categorize it according to FIGO system 1?
FIGO system 1. Okay. It was prolonged, heavy.
Show the question.
Previous slide. Yeah.
It was prolonged, because it is lasting for more than like almost 8 days. Then it is heavy, and she has 8 months, like irregular. It is irregular.
Variation more than 9 days.
Variation is more than 9 days. So from this we can say it is like from this new system it is heavy, prolonged, irregular bleeding.
Next slide, please. Next, yeah, you have correctly said. Next. This is the ultrasound image. So what is your diagnosis?
It looks like posterior is taken. It may be adenomyosis. It looks like adenomyosis.
It is adenomyosis. Yes.
Yeah.
Adenomyosis, AUBA. Next slide.
Yeah.
So on endometrial biopsy, we have secretory changes, no evidence of hyperplasia or malignancy. Next. This AUBA, as is quite obvious. Yeah, next. Next slide. Next slide. What is the MUSA criteria for diagnosing adenomyosis?
This is radiological diagnosis, we can say, radiological criteria, where we see the morphology of the uterus
Next
and
slide.
do some measurements. There we can
Please
see
play the next
certain.
slide. Yeah.
Yeah. So we can see the uterus globular, or we can see the asymmetrical thickening. We can see the posterior wall is thickened. Then sometimes we see certain focal lignomatic cyst type formation. There can be hyperechoic islands. There can be fans, septic studying. Then echogenic subendometrial lines or buds we can see, and sometimes translational vascularity is seen. Irregular junctional zone is seen, interrupted junctional zone is seen. This is mosaicism.
Yes,
In
yes.
ultrasound.
Good TVS ultrasound, we can definitely diagnose. Next slide,
Yeah.
please. So is MRI required to diagnose adenomyosis?
Not exactly. We don't need MRI for adenomyosis, but yes, sometimes we see chocolate cyst along with adenomyosis, or there can be bowel adhesions and all, which we cannot actually delineate. So that time we ask for MRI if we see endometriosis as a whole, but only adenomyosis, no, we will not go for MRI.
In old times, it was written that adenomyosis is diagnosed mainly by MRI. That is what the definitive. But nowadays, transvaginal ultrasound is much or equally sensitive to pick it up. We do not need. Any gynecologist can.
Next slide, please. So as you can see, the sensitivity of 2D TVS is 84%, 3D TVS 85%, and Doppler 94%, and MRI is equivalent 88 to 93%. So we can very well go ahead with TV ultrasound, and it is definitely less expensive and than MRI, and MRI has its own issue, like claustrophobic patient, they don't get generally agree for MRI as well. Next slide, please.
Most of the features are like correlating also, TVS, MRI, so better we'll go for TVS.
TVS, yeah, easily available, very easy to do.
This patient is insisting on hysterectomy. How would you counsel her?
Yes, if she is from an area, actually, I work in a small town where I do get patients coming from kilometers away. So if she has the problem and she cannot come again and again, so I will prefer for, if she is insisting me for hysterectomy, I'll go for it, because she may not come next time. But the treatment, if you say like you work for, is I can just put an LNG and send her, or for some time, like 3 months, we will see if she is tolerating.
LNG minimum 1 year, not it will not be effective in 3 months.
Pardon?
LNG will not be effective for 3 months. It should be given more than 1 year.
No. Actually, sometimes what happens, I do get patients from long time, like distance. I'm saying, that if she is tolerating it, I'm saying tolerating it because sometimes you get so much of troublesome bleeding after putting LNG IUS. They get heavy also. In between also, it is not culturally acceptable also. So sometimes we counsel also, but after that also they say that I cannot tolerate this, please do hysterectomy. So because of that, I'm saying that if she is tolerating, or if I'm giving some hemostatic in between, if you get spotting, you take this medicines, so then it is fine. We can send her for 5 years. But if she's coming from a far away place, then if she cannot come for days, or if she will go to some other place again. I have gone to this doctor like Jorhat, then she will move to some other place which is probably farther than this. So we need to check which category of patient it is. If it is from a very low socioeconomic strata where she cannot afford to come back to the doctor again. So in this situation, if she is insisting me for a hysterectomy, I will give her rightful, I will honor her decision and will go for this. But yes, if I can counsel them and we can assure them that this disease will be cured once you get menopause, then yes, we'll go for medical management with LNCIS.
Yes, very well said. You should definitely counsel her regarding the pros and cons, and the patient decision should be honored in this case. And many patients have severe dysmenorrhea, so they really want to get rid of the uterus.
Yes.
Next slide, please. This has been discussed. Next slide. So we come to the last case scenario. Dr. Jaishankar, if possible, if you're audible, please answer. A 47 years old lady come to our OPD with chief complaint of heavy menstrual bleeding for 6 months. Her present cycles are for 7 to 8 days, every 15 to 25 days, and she soaks 8 to 10 pads per day associated with clots. She is para-3 living 3. Next slide. Her speculum examination reveals cervix, vagina healthy, and on PV examination, cervix is mid-post, uterus mid-post, 6 to 8 week size. Next slide, please. So how do you categorize it according to FIGO system 1? Dr. Jaishankar? There's some issue with your microphone, I guess.
Ma'am, in the meantime, I'll just answer one a little bit of it. Like it's 15 to 25 days, you said. So it's frequent, that irregular, frequent, and heavy.
Yeah. Thank you. Next slide, please. Heavy, frequent, prolonged, and irregular menstrual bleeding. Next slide. So this is the ultrasound image of the lady. So, Yosna ma'am, what is the diagnosis?
It looks like a fibroid because it is irregular and this indenting the bladder also. So it looks like a fibroid.
Posteriorly, a fibroid is seen also. In posterior side, there is a 4-5 centimeter.
Posteriorly, a capsulated fibroid is seen. Yes. So this is a fibroid and endometrial lining. I cannot comment on this exactly on this picture. So that also should be.
Maybe in some other aspects, maybe some other view of the ultrasound, it will be seen.
Yes.
What will be the sub-classification according to FIGO?
This AUB L.
Which type of fibroid?
Ma'am, this looks like 2 to 5, that one. Like from the endometrium to the serosa, it looks to be like that.
Actually, the endometrium is not that clear.
Yes.
It's a slight abating of the serosa of the uterus.
Yes.
It looks as if it's from the endometrium to the serosa. That's why I said posterior aspect. So it looks like 2 to 5, that one. 2-5 like that. Something like that.
From endometrium to serosa.
Yeah, so 2-5, that one.
Yeah, you're correct. Next slide, please. Next. So it will be AUB
L
definitely.
With 2-5.
Next slide, please. So whether we'll go for an endometrial biopsy in this case?
Yes, of course. This is 47 years of age and also with the AUB. Any type of AUB should go for endometrial evaluation before going for the diagnosis.
Sometimes it is combined also. The fibroid may be combined with hyperplasia
as well.
Yes.
Next slide. So on histopathology of endometrium revealed secretory changes and no evidence of malignancy or atypia. Next slide. So she is also insisting on hysterectomy. So how you are going to manage her?
Again, this patient, 47 years of age, approaching menopause, but with multiple fibroids, should be counseled. And I will give her medical treatment for 2-3 months. If she improves, and she can take a conscious decision after taking the medical management. Because many patients, they have not taken any medical management, so they do not know what is the power of this medical management also. Because she is approaching menopause, so I will advise her that everything is normal. These small fibroids, multiple fibroids may regress after menopause. So you take some medical management and wait. So during this her medical management, she can take a decision. If she takes decision of preserving the uterus, then I will think of a LNG ICD. Or if she takes the decision of this hysterectomy also, I may honor the her decision. But I am personally for medical management because secretory endometrium is there and she is approaching menopause also.
What medical management you prefer?
This patients usually progesterone because she is having frequent cycles and also heavy cycles. So continuous cyclical progesterone will help her.
May I add something?
Cyclical.
May I add
Yes.
something with due permission?
Yes,
Yeah.
ma'am. Yes.
We have seen such patients works very good with newer modality of fibroid treatments, which are coming in the form of mifepristones. And they usually have the benefit of having amenorrhea once they start the treatment, which usually goes on for like another 3 to 6 months. And meanwhile, they build up their hemoglobin. And sometimes this that causes shrinkage of myoma also. I do not know whether it will be effective in this big tumor or not, but that induces amenorrhea for 4-5 months. That will give her time to build her up, and then we can stop the treatment for a few months, and we can see. Sometimes it brings a permanent result also. Many patients are being managed like that.
Yes. We have given many
I want to
patients
know the
with,
opinion of other doctors
mifepristone.
actually.
Yes, I
because-
have given. But this treatment, you think, but you can continue for 3 to 4 months only because it's a costly, expensive drug also.
Yes.
And some people may not also, this amenorrhea, they may not, it's not good. So they think that amenorrhea sometimes, whether menopause or not, because it's secretory endometrium, maybe progesterone will help because in secretory endometrium, usually they have estrogen receptor, so they will respond to progesterone. If it would have been proliferative endometrium, anovulatory cycle, then this maybe mifepristone I will. And also there are other Dynogest, all things they have tried many types of all the types of progesterone and also mifepristone, and also with this some non-specific drugs, the like this Fibronorm, they have also
People are
tried.
using. I just want to know.
I have used mifepristone. I have used mifepristone and also progesterone. Both are equally good. And as you said, this mifepristone, they cause amenorrhea. Easily amenorrhea. They cause easily amenorrhea.
Ma'am,
So that depends upon the patient. Some people they like the cyclical menstruation. In you have to see the patient profile. If they want that they cyclically they have to menstruate, then we can go for cyclical progesterone.
Regarding the chances of amenorrhea, patient counseling should be done.
Yes.
Win, ma'am, what is your experience?
Is also used nowadays. Again, it's back in the market, and the DILI, that is the drug-induced liver injury, is usually found to be reversible. So, like there was a lot of hue and cry. Sometimes it's banned, sometimes it's there, but now currently it is also there, and the current evidence is not speaking against it either. So that is also an option.
Before starting,
Yes,
treatment,
Ulipristal
we should
also
go
we
for
have
a
tried.
LFT, and accordingly we can start and monitor the LFT as well.
Yes, ma'am. But there is DILI, that is drug-induced liver injury, but that is found to be reversible. But nevertheless, every 2 weeks or so, we have to keep monitoring the LFTs.
I have a question for the panelist, one more. So suppose the patient has Googled and she Googled about Mirena and she's telling I want Mirena. So would you give her?
Yes, we can also try. But in this case, API.
If the cavity is very distorted, it might be the insertion
Yes,
might fail.
Yes.
We have to count.
Yes. So again, we have to see a good picture. We have to see the cavity. And if you have done the endometrial biopsy through hysteroscopy, then also you have evaluated the cavity, and that time you can decide about the whether I will go for Mirena or not.
Yes.
So one question: if you are doing a hysteroscopically guided biopsy, then whether you give the Mirena, insert the Mirena at the same time.
So ideally, we should insert after we get the histopathology report.
Yes, yes. I always do that, but some colleagues, they, because of anesthesia, they think that I will give put,
Yes.
but I am also in for
So
of
be pain-free,
after the
you are pain-free
evaluation.
for the patient.
Yes, yes,
In
yes,
Cool,
yes,
ma'am.
yes,
better.
yes,
Ma'am,
yes.
some patients,
Because
some
if
patients
I
don't want to go to anesthesia. So
Yeah.
when after explaining the whole thing, they will say, I have had 2 cases who said after hearing the whole story, they said, please put it in the same sitting. If my biopsy comes, something wrong comes in it, then I will take it out and proceed. And I have done this in 2 cases because that is what was the patient's wish. That in case it comes normal, then I will be
yes,
saved of another sitting of anesthesia and
yes,
hospital
yes.
admission.
Yes, some people may say for whom this cost does not much, that does not affect them much, but because it is costly, so we think that after evaluation, if I have sent something for evaluation, after the report comes only, we can decide.
The madam, patient was telling you put, and after that they will remove it comes, but it is too costly. Are they able to afford?
Yes, yes, that I'm telling you. Yeah.
Yeah,
It depends. Some people, some.
Ma'am, 2 times hospital admission, 2 times anesthetic charges is also payable. So it comes to
No,
the
we do
same
not
thing.
put. No, for Mirena insertion only, we do not give anesthesia in OPD.
We do not
only.
admit also. It is in just
Yes,
an
yes. In only OPD procedure only. OPD.
simple as
Only
property
OPD.
insertion.
Yes, yes,
So
yes.
will not do without an anesthesia. I know many of you have
Yeah,
faced
there are
that.
certain patients they insist for
Will not do
anesthesia.
without anesthesia. So that is one point.
So with this, we conclude our panel, and my sincere thanks to our esteemed panelists for their valuable inputs, and Abha ma'am for her expertise.
I would like to convey my regards to my teacher, my Abha ma'am. I am really happy to see you, ma'am, again. It was really great. You are still as young and energetic as those days.
Thank you so much. I joined late. I missed many things.
So much to both our moderators. They have done such a wonderful panel. Thank you so much. We really enjoyed participating.
Thank you.
However, I actually, we had a very excellent panelist. They are so active, and Dr. Quincy is so well prepared. They asked me also yesterday what year. So yeah, I really enjoyed the panelists. All are well.
Wish Dr. Jaishankar Sir's input due to some problem with the audio.
Abha ma'am, thank you.
Actually, Dr. Jaishankar has muted his
He unmuted, but
audio.
still
Yeah.
it's not audible after unmuting also.
I have to go to labor room, and so I have.
Thank you,
It was
Sindhu
nice
ma'am.
having you all, and it really brightened my knowledge, and it was very nice to have you all, and including me. Thank you very much, my moderator and my education committee members. Thank you.
Thank you so much.
Thank you.
Thank you so much, ma'am.
The organizers, thank you so much.
Thank you, Dr.
Thank you,
Monica.
organizers.
Yeah. So I think we can leave the meeting.
Yeah, thank you
Dr.
so much.
Satabdi?
Yes, ma'am.
Yeah.
Thank you, Soumya ma'am. Thank you, Abha ma'am. Thank you, Madhusmita ma'am, and all the esteemed panelists for a beautiful discussion. That was a very, very exhaustive discussion. I was thoroughly into it. Thank you so much, everyone. Once again, thank you to Jaideep sir, thank you to Shamal sir and Janmajaya sir. Thank you to our chairpersons, our speakers, Joyanto sir and Himali ma'am. Thank you all on behalf of the Public Awareness Committee. Hope to see you all soon again. Thank you all. Have a very good night, all of you.
Thank you. Thank you for the opportunity.
Thank you. Thank you.
Thank you so much for the opportunity.